population cohorts. My background is in NHS management, 30 years plus in NHS management, but with obviously a particular interest in addressing health inequalities and bringing that prevention, primary and secondary prevention that we were talking about in some of the earlier sessions into our treatment pathways. If people want to put in the chat who they are and where they're from, just so that when we're talking to each other, we can have a bit of a reference point. And it would be great if you're able to put your cameras on, because this is going to be a discussion. So if we haven't got time to introduce each other individually, but if we could kick off, what we're interested in is initially is, as Anne introduced the session, a couple of things, either observations on the speaker, from the speakers that we heard from this morning about health literacy, and or your observations from your own sites that are relevant to the content this morning, and particularly feeding into the evaluation of this work. What do you think of, what are you most proud of in your sites? What things do you think should be sustainable, and what of your major challenges been? So if I can open it up to a brave person to kick off our discussion, hands up to those who've got any comments on the session from the speakers that we had this morning. Thanks, Lisa.
Hi, everyone. I just wanted to speak about how interesting, the health literacy presentation was, and how important libraries and books are, access to those spaces. Because in our area, I work in Cheshire East. Cheshire East Council have completely slashed the access to libraries for our local residents. So there's been a number of library cuts, and they're closed most of the week now. So it's just you're up against what was presented today, which makes sense, and you can see the benefits, and how easy it is for people to meet in those community settings. And then obviously the other hand, you've got all these resources just being cut because of the financial constraints from the council. Just something that's I actually live in Stockport. I don't live in Cheshire, and our local library has shut all the the free access in terms of having staff members manning the thing, but they have something called open access, so you can use your library card to still access the buildings. So that's one way around what I know a local authority has done. But I just wanted to say how up against it is really, with competing priorities from different organisations.
Yeah, thanks, Lisa. It's interesting. I about 18 months ago, maybe a couple of years ago, having been the author of this particular programme and an interest throughout my career, but I started saying this is probably the best thing I've done. I've done some good stuff in 41 years in the NHS, 31 as a GP, but this is probably the best. And there's a question, whilst I still teach undergraduates, and we've still got to teach it from the medical viewpoint about disease of the body parts and cancer and heart disease and respiratory disease, I still reflect on if the social determinants, the wider determinants, were addressed in its broader sense. For example, if nobody smoked or drank alcohol or rode a motorbike, I'd have probably been out of a job and had a good diet during my career. I'm not trying to marginalize it to a point, but there's a sense of this is so important, but it still feels like a bit of a Cinderella subject. And when you start talking about the importance of libraries and the impact it can have, I talk to colleagues in Department of Health or NHS England, they'll still be saying, yeah, I know, but we've got the winter bed crisis to sort out and the orthopaedic waiting list, which are really important. But there's a sense of how do we embed some of the work that we heard. And I see Professor Julian Manley, a colleague of mine at UCLan, on the call as well. We're looking to do some further research into seeing if we can explore issues that are inherent in communities that lead them into bad health outcomes, but we're still not quite knowledgeable about. Julian, I don't know whether you want to say anything about that, but it goes back to the 10-year plan, which hopefully will just not be on about how we reduce waiting lists and improving hospital services, as opposed to some of the work that's that we'll hear about from sites later on as well. Chris, good to see you.
Hi, and you. Yeah, I suppose you've talked before about, we've all talked about how the kind of focus of the project moves depending on what emerges, and maybe the end result. Well, this health literacy thing is fascinating, but maybe the end result is going to be that the pooled knowledge that we get out could actually inform some really powerful lobbying material to take back and actually affect some of these changes centrally. I mean, does that make any sense?
Yes, and I think Paul Batchelor was saying about, again, the allocative value. I've probably a bit emotively used an example, because I was hearing from one of our sites about their work on adverse experience in childhood. They were working with 6 families who had, a couple of them had ASBOs. They all had children with complex needs, some with mental health problems, all of them going to bed at night with their bellies empty, probably school excluded. And they were running a programme for these 6 families on less than £15,000 a year by the nature of the input. Now, £15,000 a year buys 1 hip replacement. So in the 10-year plan, if you've got to allocate £15,000, we know ICBs are stretched and they can only allocate it once. Are you going to get a white middle-aged man needing a hip replacement back on the golf course who can vote? Could be me. I don't need my hip replaced yet. Or are you going to look after these 6 families with complex needs who might, if they have that intervention in these adverse childhood experiences in those young age, may lead them into a much more productive life? And they were looking at each of those lives, if they're not impacted at that age, might cost £1 million in public services through social care, through the justice system, and not being in work, as opposed to doing something. Where's the ICB going to put their money, or the 10-year plan? It's going to be the hip replacement every time. And it's how do we change the mindset to say we've got to think about, it's just an example of allocative value, where the first session we've had, there's still a sense of, we can't invest in this when we've got such pressure on the known NHS, whereas the unknown issues that lead to those pressures might be, we talk about prevention or going upstream, be dealt with by different types of interventions. And I'll reflect on that to Chris. Does that make sense, Chris? Sorry, Liz.
I think, Chris, sorry, just butt in a bit there. Chris, you're absolutely right that, we are, what you're suggesting is, we use the evidence from this to lobby and to present evidence to try and influence policy. And so, one of the things we want to try and get out of this session is an understanding from those of you who are working in sites at the moment, what are, if we were to write a kind of a set of principles of what are the do's and don'ts of addressing health inequalities, what would you be putting on that list from your own experience? And that, that's part of our evidence gathering is the feedback that we collect on these sessions. Liz.
Sorry, it's just going to that point about where does the investment go, and is it the white man with the hip transplant or not? Because I'm working on a project in Kingston and Richmond, so I work for the ICB, but been working with 2 PCNs, and it's sort of social prescribing plus. So it's a service that's embedded within our social prescribers, but they actually go out and do outreach work as well and do some targeted contacting patients that we've identified through population health management, through clinical systems, and doing some targeted work. And we have that challenge. The funding runs out in the end of March, and at the moment there is no money. It's all going to beds. But yet, when we look at, so it was interesting to see that the article that I can't remember who it was he mentioned earlier about showing now to demonstrate the impact of social prescribing. That's what we need to be able to say it is actually having an impact. But one of the things we're doing is we're flipping the focus of our program in winter. So initially we were looking at people with long-term conditions and trying to work with them. But actually what we're doing for winter is looking at people with COPD and people who haven't had their vaccines. And the project is going to actively reach those people so that we can try and tick a box to show we are also helping to keep activity out of the hospital. But that ongoing frustration of how do we evidence something that's going to have an impact in the medium to long term, when all the finance people are thinking about is tomorrow, or even today sometimes, some of the meetings we go to. So anything we can have, any evidence that can demonstrate the long or medium term impacts would help in the projects we're working on at the moment, I think.
Debbie.
Yeah, just picking up on
Debbie.
Liz's point, actually. I think there's, well, for us, we've been able to evidence the successes of social prescribing through the investment that we've taken as a PCN using Joy. Now, our social prescribers, our view was very much to have our social prescribers in the community, to take a different model to what others have done. You know, many are sitting in practices. And the reason we did that is that we wanted to really kind of change the mindset of patients. You know, those social needy coming through the primary care kind of outlet, which is the only route they've probably had previously, is moving them into the community setting so they become not patients but clients. And what we've actually done, it does take time to actually evidence, but what we've been able to show is that actually patients' behaviour and the investment of social prescribing is working, in that we've seen a reduction of those people. The usage of appointments is down by 50% in 12 months. So it kind of picks up behaviour before engagement with social prescribing, pauses while social prescribing is involved, and then restarts and looks at their overall activity with GP practices for 6 months. So we can talk very confidently in relation to reduction in demand in practices. So GPs are bought into it, so the reinvestment into Joy, because we do have to buy it. Yeah. But actually, as a PCN, we've seen the definite kind of the value of that, but also the additional opportunities, I suppose, that it's been able to give us is that we've got our own marketplace that we've developed. So all the local kind of organisations and the wider organisations that our social prescribers are using, but also what we've done in our community, because part of my role is community management, is linking in with the likes of Liz and the libraries to show what we can actually do locally to our local community, and that is available to anybody. So whether it's practice staff looking and trying to actually engage, so our care coordinators can talk confidently what's going on about activities to improve isolation, for example, or our community themselves can look at Joy to see what's going on. And there's activities for all different ages, disabilities, you know, there's some for men only, women only, all sorts of kind of different groups. And we've got quite a diverse population to which we feel that it's not perfect by any means, but we're getting a long way forward to helping make kind of further adjustments to people and giving them the control to be actually kind of make that change as well. So I think that's probably, I know one of the key points for today was what is our, you know, what do we feel is successful and what will give us kind of longevity. I feel this is something, and I'm really blessed that, you know, again, I've had the opportunity to be a community manager. There was a little bit of funding came available, that, you know, that's ended, but that benefit, I think, for practices, because I've worked with the practices before as a practice manager, I understand their demands and obviously the opportunities that are available, and we're working differently within our patch. A lot of what we're doing is in community settings. So the vaccine centre, for example, I managed that. The pandemic stopped, but we carried on working at scale through the vaccine centre to remove pressures on practices. We do the flus, we do the COVID. We've developed it to do, as we end there, we're doing kind of community diabetes work, and we're seeing people coming through the doors that historically won't go through GP practices. And then the other shift, sorry to feel I'm talking a lot, but I just feel the other shift we've seen massively, which we didn't forecast at all, but referrals into our social prescribing teams are coming probably from a greater number of organisations than our practices now. And that shift is massively different. And what's pleasing to see is that they're possibly seeing people that we're not seeing necessarily and engaging within primary care that do need some real help and support. So MPFT, DWP kind of departments, job centres, various other organisations. We've got probably over 40 different providers coming and referring into our social prescribing team. What's the issue? I think for us, I'd love additional funding from our ICBs or wherever nationally to grow the team. We're nowhere near, we're scratching the surface and looking at research. It's going to take us another 13 years carrying on at the current rate we're at to continue to deal with the issues that we've actually got and the size of the challenge. So further investment, if you could take anything away, James, to grow the team would be an absolute plus for me today. Thank you.
And
No, thanks, Debbie.
Sorry, James. Just a
go on,
quick
Becky.
Yeah, a quick question for you, Debbie. Having collated some of that evidence locally on your site, are you finding that evidence is enough to sway the ICB and commissioners?
Yes, I think the ICB, it's taken a couple of years for them to actually kind of start to see, but because we can talk about stats and prove that social prescribing is working, they're now looking to do investment for other areas to actually have joy across Staffordshire and Stoke. Some have already got it, and that's enabled them. But I think where for us the greater gain has been with continued investment from GP practices, and also we forged good links with our kind of local kind of council, which has always been a very difficult one to get access to for years, if I'm honest. And we forged a really good relationship. They've seen the benefit of what we're trying to do from health, and they can understand obviously what their goals are actually doing. And they this year have subsidised. We have our own form filling service because we could see that was a real gap in our area. We hadn't got that facility. So we as a PCN have funded two people to do form fillings to support people with literacy issues and kind of, various sort of challenges. It's a closed service, but the benefit of that has been over £750,000 of benefits secured for that population in very high deprived areas. So they've funded £15,000 to help support the form filling service to continue for the next 12 months, which I think is a real kind of, real plus, a real win for us. And hopefully if we can continue to show them the values that's bringing, but also social prescribing, that investment will be returned again and repeated and hopefully kind of continue to grow, because we're actually achieving and supporting some of what they're aspiring to do as a council.
Yeah, there's just making some really interesting points about establishing the evidence, and the evidence that often only requires a relatively small injection of resource. But even so, when I think everyone's talking to a commissioner, the first thing is, if you're asking for money, don't ask because we haven't got any. But it's how that evidence is established, where sometimes the metrics that are important to the system are not the same as the metrics that are important to the people or the actual service that's providing it. And we're having some difficulty where, if you've got evidence that, let's say, you've reduced social isolation, individual mobility, greater agency, better self-care, it's still a case of the system says that's all very good, but we've still got long waiting lists, as opposed to what you were saying, Debbie, where you're saying we've got a reduction on demand and improving access. That is a big ticket issue. And it's sometimes frustrating that the big ticket issues for the service, which are often about waiting and access. And then the other issue is, as you uncover more, let's say, unmet need in a community service, and there's more referrers into that service, that increases the demand on the service. It's a difficult issue because we know about the massive amount of unmet need. So I think we've got to be careful or clever about establishing the evidence that aligns some of the things that will awaken the commissioner in how they're being performance managed. There's terrible pressures on the commissioner as well, but usually that is from government or DHSC, which is the public's, I said before, the public's top concern is waiting and access. So things that reduce waiting lists in hospital, recovering access to general practice, because it's always a case of, I can't see my GP for 3 weeks, MP, as well as the metrics that are important to the people that are, about, well, I feel more able to go out and visit my grandkids, and that has made my health so much better. It's not something we recognise as a an evidence-based, albeit high impact, but it's not one of the metrics of the system, if that makes sense. So it's how we can align the work that you've described, Debbie, that, you know, you've already said it, the impact on demand, recovering access and improving access is always going to be a big ticket issue. How do we make sure that's aligned with, but the really big important issue for some of the people you're serving was that they, you know, you improve their isolation, they were able to be more mobile or access services easier.
I think you're right, James. I think the other aspect for us is we're quite a large PCN, so the data, I suppose, that's being gathered is quite substantial in relation to further evidence around, you know, inequalities. We hear a lot about it, but actually, what are we doing? How are we reaching? And Joy also identifies the postcodes of where we're actually kind of, you know, which patients are engaging. And again, our top area is actually our most deprived area. So it's, you know, things have kind of grown organically, but the evidence is starting to kind of, you know, develop more and more around what we're actually achieving. I think also the local links and the marketplace has been a great one, that, you know, because organisations talk to one another, it's a free service for them to promote, and that's been another added benefit for I suppose really kind of joining forces more in, you know, in the community setting has been really kind of valuable. I think the other trend that we're seeing is that we're not seeing increased activities in going into A&E. We've stayed very stable, which actually most others nationally have kind of had this continued hike. Our population's continuing to grow year on year, as most probably are, but we're not seeing that shift into A&E at all. So we're holding our own in relation to that work as well. So I think, like I say, it takes a while, it does, but I think having a couple of years into this now, we're starting to really see some good momentum.
Any colleagues who've not had a chance to speak? I know we're going to be pulled out of the room in about 6 or 7 minutes. But any other comments, reflections, thoughts? Julian?
Yeah, thanks, James. I think this morning has been really, really interesting. So thanks for organising that, James. I think one of the issues here, of course, is the incredible complexity of what we're talking about. And I think some of these complicated and very important things came out in the discussions before, in the talks before, such as, for example, the comment that libraries are not just about books. That was almost a passing comment, but the importance and value of that can't be underestimated. And then the comment that social prescribing as a choice for GPs is, the word that was used was a luxury. And that GPs will be assessed on very measurable outcomes, and that social prescribing is simply could be regarded as a luxury. And then there was another thing I noticed about how there are political divisions in the support for the CCCP, which I find interesting and somewhat concerning. I don't quite know what kind of political divisions we're talking about, what kind of opposition there might be to this kind of program. And I think it would be really valuable to try and understand what kind of opposition there might be to supporting a whole-scale well-being program. So all of those things I think are fascinating, and really what it points to is that we're talking about systemic change as opposed to treating certain health conditions. So the system either has libraries that people trust and that are providing more than books. The system has an acceptance of the importance and value of social prescribing so that it's not a luxury. The system accepts the common sense of a CCCP program as opposed to interpreting it as some kind of political yes and no thing. So, you know, how do we bring about the systemic change in society and communities that enables deeper and more profound and importantly more sustainable change to public health outcomes. Because I think one of the deep issues here is what happens when interventions run out of money, or what happens when we can no longer do this and that. If the system has changed, as it were, inwardly, then the legacy and sustainability of these things can continue. But if the public health improvements are, as it were, temporary, because they're based on interventions in certain places and certain times, then they may not last beyond the different programs that are put into place. So I think these are challenges, and it's fantastic to see the positive results coming out of the CCCP. And I think a very vital point is how do we address the system that might prevent continued improvements. I also think it's important to reassess measurement. I think the measurement of the most important positive outcomes is something which is really difficult to do, and I do a lot of work in parallel to health, which is relevant. So, for example, I'm doing some work with councils on social value. And social value is a very difficult thing to measure. And there's an idea in the air that what councils might do to increase social value, which, by the way, of course, would increase better public health, is to concentrate on the inputs rather than the outcomes, and to measure the value of the inputs as opposed to waiting for the outcomes, which are difficult and in some cases impossible to measure. But I think we need to think out of the box when it comes to questions of measurement, because metrics and statistics and numbers will not measure some of the most important things that contribute to public health and to better relationships. I was doing work the other day. Sorry, I'm going on a bit.
No, sorry, Julian. I think we're going to get pulled out of the room in a minute. So just say if you're cut off, please don't think it's anything other than I think we're moving back into the room. Sorry, did you want to? Sorry, I was cutting across you. If you wanted to finish.
Yeah, I just say I also did some work last week with Forestry England on their well-being trail, and they brought in a group of refugees, asylum seekers, to walk the well-being trail. And in the mind of the well-being trail is what it says on the tin, that people feel better. But instead of people feeling better in the sense that was being studied, what came out of that particular study? Oh well.
Sorry, we're just 10 seconds off. So, thanks for everyone's contributions. We'll go back and we've only got 10 minutes to